morning, everyone. Welcome to the latest episode of Chai Pe Charcha. I, Dr. Saurabh Mundhada, Editor Chakshu, Team OSN 2022-23, welcome you all to this latest class, which I have labeled as HSC Chai Pe Charcha. Now, before I explain what is the term HSC, just go back little in time and realize when you were in your college days how much a cup used to be filled with a tea when you used to go for a canteen to have a cup of tea. It was almost a glass full when you used to ask for a full, and almost a half a glass when you used to ask for a half of cup of tea. And what after 20 years down the line, what is the demand? When you go to any tea stall, all those chains and brands, the tea gets completed in just 2 sips. What it means? The quantity, the size, everything is getting reduced. People want brand, people want quality, people want show, so that is the meaning of HSC, where people want healing faster, people want small incision, and patients are very much concerned about cosmesis. So healing, small incision, and cosmetic serves the purpose of this talk. Now, what is endoscopic DCR? Endoscopic DCR is currently well-established surgical treatment for patients with nasolacrimal duct obstruction. In the past, external DCR was considered as gold standard for NLDO. Over the past decade, endonasal DCR has evolved as an alternative treatment option and has gained significant advantage in high success rate. The advantages of endoscopic DCR over external DCR, as you all know, is lack of cutaneous scarring, preservation of the pump function of orbicularis oculi muscle, minimum risk of bleeding, rapid postoperative recovery, and most important, cosmetic. So with advances in endonasal DCR, the surgical instruments, surgery time, everything has changed. I hereby welcome our speaker, Dr. Richa Wagh, to give her talk on endoscopic DCR. She has done her MBBS from Topiwala National Medical College and Nair Hospital, Mumbai, and has completed her fellowship in oculoplasty from prestigious LV Prasad Eye Hospital, Hyderabad. She has over 6 years of experience in ophthalmology and is presently working as assistant professor in Government Medical College. She is dedicated to teaching and has taken keen interest in research work. She has presented multiple papers at national and international conferences. Other than surgery, she also spends quality time in singing, photography, and also explores avenue in the kitchen. Welcome, Dr. Richa Wagh, and I will request you to give your talk on endoscopic DCR. Over to you.
Before we start, I would like to thank Dr. Saurabh Mundhada for inviting me to this forum and the entire team of Ophthalmological Society of Nagpur for giving me this wonderful opportunity to present my work in such a beautiful forum. Today, I would be taking you through the steps of endoscopic DCR from the perspective of an ophthalmologist. So without any further ado, let's begin. I have no financial interest. So before jumping into the procedure, I would just like to take you through the basic endoscopic setup that is required. So in the picture on the panel on the left that you can see are the different telescopes. Basically, these are Hopkins telescopes that are available in different millimeters and different angles. So all of the ones that we can see over here, the first two are 4 millimeter ones, and they are 0 degrees, and the last one is 2.7 millimeters one, and usually that is in 30 degrees, and these are used for different purposes. So the 4 millimeter ones are usually used for operating purposes, and the 2.7 millimeter one is used in the clinic for diagnostic purposes while performing any diagnostic nasal endoscopies or just examining post-operative patients, or even pre-operatively if we want to examine the nose, see the size of the cavity sometimes. So that can be used. Preferably for adults, we use 4 millimeter 0 degree scopes. And even for children, like very small children, less than 1 year of age, we can consider using smaller size endoscopes. Otherwise, a standard 4 millimeter 0 degree is usually used. So other than these telescopes, the setup that we can see on the right is an entire endoscopic cart. So the top is a TV unit display. Top is the TV unit display where the entire endoscopic view is seen. Apart from that, there are two wires that connect to this particular telescope. One, the camera head that connects over here, that actually sends the display from our telescope to the display unit. And this is where the fiber optic light cable connects to provide the light for our viewing. So these are the two instruments basically. So this is the one that is providing us the light, and this is the camera head basically. So this is the full endoscopic cart. We nowadays get even portable endoscopes, but usually in a OT setup, a full endoscopic cart is used along with the Hopkins telescopes. So apart from the endoscopic setup, we must know the scope of this endoscopic surgery. So I have divided this to simplify for everybody into two different scenarios. One is where somebody who's just starting out endoscopic surgeries, and one an experienced surgeon. So in case somebody is just starting out on endoscopic surgeries, any uncomplicated primary acquired nasolacrimal duct obstructions, or that is also commonly called as chronic dacryocystitis patients, any of those patients can be taken up for surgery. Other than that, preferably doing a nasal examination just prior to surgery to confirm that there is a roomy nasal cavity, and that nose is not operated on before is important, because operated noses can sometimes have distorted anatomies, and a smaller or a narrower nasal cavity, it can be difficult to perform surgery with multiple instruments at hand. So for a surgeon who's just starting out, it is best to include uncomplicated cases while operating. But as one gains more experience, cases like an acute setting, like this gentleman who is presenting with preseptal cellulitis along with the lacrimal abscess in this case. So in this case, also we can perform an endoscopic surgery safely without waiting for him to respond to antibiotics, because it is essentially an abscess drainage from the inner aspect. This is very helpful to improve the patient's clinical scenario, especially with respect to the inflammation that he is undergoing. Other than that, cases in which there is a narrow nasal cavity that we just spoke about, as we can see in the subsequent clips, the endoscope actually is quite inside, but the nasal cavity is still not lit well. And the reason for that is because the cavity is extremely narrow. As we can see, this is the middle turbinate over here. So in these cases, putting in instruments can be a little difficult. Other cases would be in cases of ENT surgery already being done. So this is the middle turbinate over here. And we can see that a fess has been done and the ethmoids have been opened up. So sometimes to find the nasolacrimal sac in such a situation can get a little challenging. Other than that, intraoperatively, sometimes we may need to operate on the middle turbinate. Like in this particular case, the middle turbinate was extremely large. So a middle turbinoplasty was performed in order to expose the sac adequately. Which is posterior to this middle turbinate. So coming to the main surgery now. So in the operation theater, some specific preoperative preparations are required. One of them being appropriate systemic clearance from the patient's physician, and an appropriate anesthesia clearance, because preferably these procedures are performed under general anesthesia. A hypotensive anesthesia is required because, as we all know, the nasal mucosa is extremely vascular, and we must control any amount of bleeding that is possible, that is there in our hands. So a hypotensive anesthesia, requesting for a hypotensive anesthesia is very important. A thorough nasal decongestion is done prior to starting the procedure. So this is nasal decongestion being done, followed by mucosal infiltration with 1:80,000 adrenaline. And this is followed by nasal packing that is done prior to surgery. So all of this is done in order to adequately decongest the nasal mucosa, in order to shrink that mucosa so that there is some more space for us to operate. So now coming to the main procedure of endoscopic DCR. This is the middle turbinate as we can see, and this is the axilla of the middle turbinate. So basically that is the attachment of the middle turbinate to the lateral nasal wall. And this is the septum and this is the lateral nasal wall. So basically we are operating on the left nasal cavity, just to give you a small orientation of the picture we are looking at. So nasal mucosal incision is performed 10 millimeters above and anterior to the axilla of the middle turbinate. And this is in the shape of U, so to speak. And once this is done, the mucosa is lifted with the help of a periosteal elevator. And after adequate lifting, if we feel the mucosa is bulky, we can debulk the mucosa using different adjunctive techniques, or even a small, simple scissor can be used. In this case, there was no requirement to debulk the mucosa. An osteostomy is directly started. So in external DCR, we usually puncture the lacrimal bone and then we begin the osteotomy. So in this case, the lacrimal bone is directly punctured with the end of the ronger, and osteotomy is begun. And we can confirm the presence of the site of the osteotomy by just simply pressing on the sac. As we can see further, this is the sac, and if it is pressed on externally, just like we do Roplas, this will balloon out and confirm the presence of the sac and confirm our site of surgery in case of any doubt. So an osteotomy is performed all over around the sac area to expose the sac adequately. So this is a powered diamond burr that is being used to basically remove the superior bone. Now, this is the superior thick frontal process of the maxilla that usually even in external DCRs, we sometimes find it is very thick and difficult to remove. But from this approach, it gets difficult to insinuate underneath the bone and use a punch to actually remove that. So a drill is preferred in such cases. And this actually I consider as the most important step in an endoscopic DCR, because this step is going to expose your superior part of the sac, because as we know, the frontal process of the maxilla thickens as it goes more superiorly, and sometimes even in external DCRs we find it really hard to insinuate underneath the bone and punch the entire bone out completely. So from the endoscopic side, it becomes very difficult to do it with a ronger. So preferably an endoscopic powered instrument like this powered drill, or using a diamond burr, is used to expose the sac from the superior aspect. And the reason for that is that the superior most aspect of the sac, where the fundus lies, is where the common canalicularis opens into. And that part needs to be opened up in order to improve the drainage and start the drainage of the lacrimal system again. So in this particular scenario, as we can see, there's a probe that is inserted from the punctum, and an indentation of the probe is actually showing you that the sac is tenting out really well, and the bone has been cleared adequately over the sac area. So after confirming that adequate bone clearance has been achieved over the superior portion of the sac, we then make sure the lacrimal bone that we had initially punched into is removed, and then using a crescent knife. And this is something different that I have seen that usually ENT surgeons don't use, because this instrument is easily available in all ophthalmology setups. So a crescent is a very useful instrument to make this incision, because it gives you a very precise area in which you want to create that nick over the lacrimal sac. And it not only helps to perforate the sac in a small area, but it also helps to give you a clean superior incision, and it also helps you to lift the flaps, as we will see subsequently. So these are the posterior flaps being created. And then the anterior sac flap will also be created. And this is a ball probe, that is a special instrument that is used during nasal surgeries, that is like a third hand for us. So it helps us to elevate the mucosa and apply it in the place we want. So 0.04% mitomycin C is then applied for a period of 3 minutes. And then bicanalicular intubation is being done. So after this, the sac is completely marsupialized. As we can see, this is the posterior sac flap. This is the anterior sac flap that is held back by the bicanalicular intubation. And this is the medial part, lateral part of the sac. And as we can see, this is the clear mucosa, and this is the common canalicular opening. And now the nasal flap that we initially lifted is being reverted back over the posterior sac flap in order to achieve a good epithelial apposition so that healing will take place in a primary fashion. So after this is done, this step is not compulsory, but it is a useful adjunct. So if we okay, one second. So glue is being applied over the areas that have just been opposed in order to ensure that they stay in place. It is not a compulsory step, but it is preferable to do it. Then the bicanalicular intubation is tied. Preferably 2 knots are put. So in case an external removal is warranted, it can easily be done. Now, nasal packing is to be done. Now, one must make sure that the nasal pack does not reach the site of the surgery. Secondly, if we are putting in an intubation, then the pack should not entangle within the intubation silicone tube either. So it has to be done under careful visualization, preferably just applied onto the floor of the nasal cavity below the inferior turbinate, and then the anterior portion is successfully packed. So this is just a brief uninterrupted view of the entire procedure that we just saw in detail. So the nasal mucosal incision is done, followed by lifting of the nasal mucosal flap. An osteotomy is created, which is then extended. Adequate bone removal is done with the help of different instruments like the power drill that we can see here to achieve a good superior clearance. This is followed by creation of anterior and posterior sac flaps using a crescent knife. These are then folded back in place with the help of a ball probe. Mitomycin C is then applied for a period of 3 minutes and bicanalicular intubation is done. The nasal sac flap is then turned back to oppose the posterior sac flap, and glue is applied. Intubation is then tied. Adequate nasal suctioning followed by nasal packing is then performed. So this in brief was the endoscopic DCR procedure.
Thank you, Dr. Richa, for a meticulous surgery. What I understood is in initial days when I used to do a DCR surgery in college and initial years of my practice, so 2 assistants were there. One used to constantly mop, the other one used to hold some of the other structure to clear my view. So in all, 3 surgeons were like they were more expert than me. So total 3 people were involved in doing one single procedure. And now time have come when you are single-handedly doing such surgeries and no need of many assistants, and view is very clear and you can pinpoint exactly to the level where you have to see. And most important, there is no mess and no blood filled spaces. So I really love this surgery what you have shown, and we hope everybody in Nagpur will be keen to call you for endoscopic DCR. So we have a few questions to you. We'd like you to answer those questions. They are very basic questions. Like the first, which everybody has in their mind, is what is the difference between keynote differences between external DCR, which was commonly performed by ophthalmologists, compared to a endoscopic DCR? which till now was a ball game of ENT surgeon, and now many ophthalmic surgeons, oculoplasty surgeons have like started doing the procedure and having greater success rate. So I would like you to address few keynote difference in between the two kind of procedures.
So basically, one is you have to know the nasal anatomy very, very well if you are going to perform an endoscopic DCR. And that we do not pay too much attention to, especially like while learning external DCRs. The basic, as a PG student, whatever nasal anatomy we are supposed to know, we just read it more for theory rather than actually understanding what is going on. But as I gain more and more experience, I'm realizing that the nasal variations are very, very frequent. And one must be aware that these variations can exist in your patient while doing the endoscopy. So, understanding that anatomy is very important for an endoscopic DCR. Secondly, in an acute setting, patients in our part of the world do present with acute dacryocystitis, lacrimal abscesses, and recurrent, such episodes, in spite of being advised surgery by many, many surgeons in the past. And this is a very common scenario in many institutes at our in our part of the world, basically. So in this scenario, providing a quick relief to the patient, endoscopic DCR is very useful because you cannot perform an external DCR in such situations. You have to conservatively manage the patient. If there is a fistula or a broken lacrimal abscess, you need to wait till the wound heals. Even if you want to perform the surgery, we have to wait a minimum of 10 to 15 days for that wound to heal or even that inflammation to subside. Even then, if you perform it as early as 10 to 14 days, you are going to find some amount of inflammation in the superficial tissue that in an endoscopic DCR we are not opening at all. So in an endoscopic DCR, we are essentially just marsupializing that lacrimal abscess completely into a so to say septic cavity. A nasal cavity is not aseptic anytime. So basically, we are not causing any harm to the patient. We are just opening up and letting it drain without touching the actual inflamed portion.
Okay.
So an acute setting would definitely be endoscopic DCR would definitely score over an external DCR in that. And like you mentioned regarding the experience, as ophthalmologists gain more experience in this procedure, we do understand the lacrimal anatomy, the puncta canaliculus, and lacrimal sac in general. I believe better. So in that case, when we operate through the nose, we are paying more attention to other problems that may coexist in these scenarios, and we can tackle it in the same go.
You have used specifically glue. Are there any other techniques available? And what is your choice of technique? Like I have heard of clips, etc. So any other techniques are available?
Okay. So, fibrin glue, like I mentioned in my talk, it is not compulsory to be used. It is basically blood products. So, some amount of bleeding does happen during the surgery. So, natural oozing of that blood that forms a layer around these flaps that we have created also gives the effect of glue. But applying fibrin glue is advantageous in the sense you know where exactly you are applying that and you are intending to put that film in that area. That's about it. Because once the patient is up and about and mobile, those flaps may not remain in the same area. Plus, post-operative edema may actually close your nasal cavity and make it really, really narrow. So in those scenarios, this is just helping you give a more predictable result. I have only read about clips. I have had no personal experience of either watching somebody else do it or performing it. So I have very limited information on that. But other than that, if I can, I would like to just share some other adjunctive things that we can do in an endoscopic DCR, and I like to call it as allies in our OR. Okay, so what we were talking about as allies in the OR. So this can be powered equipment. One we have already seen the diamond burr. The second one actually is a micro debrider. So this is how a micro debrider looks. And sometimes to debulk the mucosa, nasal mucosa that we have just lifted, because it can be a very troublesome if it's a very large bulky mucosa that can come in the middle of your entire surgery. And that is very unnecessary. Even that length is a little extra sometimes. So that can be debrided in order to provide a good view. And in the end also, it will oppose well along with the posterior sac flap. So that was the micro debrider. The second one would be a diamond burr that we have seen in detail to complete your superior osteotomy. And mitomycin C, as we all know, has been used in external DCRs as well. And these two adjuncts, mitomycin C and bicanalicular intubations, are definitely more useful in cases of pediatric DCRs, in cases of traumatic DCRs, where you are just improving the chances of your success. Fibrin glue also we have discussed. So the last one is a balloon dacryoplasty. So this actually is sorry. So this is a stenosed ostium actually. And in this case, we have performed a balloon dacryoplasty to expand that size. So a cardiac catheter actually, over which a balloon is placed, is passed through the punctum after adequate dilatation. It can be passed through either punctum. And as we can see, using 8 atmospheric pressure, this is applied for 90 and 60 seconds in order to dilate the ostium and the common canalicular opening adequately post the procedure. So these are all adjuncts and they can be used as and how required.
Okay. Can you please comment on the failure rate as well as recurrence rate in endoscopic DCR as compared to external DCR, particularly with regards to flap size, the ostium size, and everything?
So there are multiple studies regarding this also in the past, like you can say 70s and 80s, and as compared to now, which are done, after 2000. And those studies were basically done by a different group of surgeons. So the rates were success rates were as low as 59%, 75% in some studies. But now, like I have mentioned before, as one gains more experience in this procedure, plus the availability of high powered instruments and such a good view, improved quality of displays as well, like we all saw. The success rate is definitely going to rise. And at present, in experienced hands, the success rate of endoscopic DCR is as good as external DCR, and I would put it at 95 to 99%.
One common question every ophthalmologist and a cataract surgeon has: after how much time can we proceed with a cataract surgery following a DCR? So, is there a difference between external and endoscopic DCR time wise for proceeding with cataract surgery?
There essentially isn't, because technically we have performed the same procedure. It is just externally we have an external incision. Otherwise, the procedure essentially remains the same. So you commonly actually we say 3 to 4 weeks is because there have been studies done wherein the flora of the conjunctiva has been studied in detail, and it has been noted that the clearance of that flora happens in around 3 to 4 weeks. So that is why we usually prefer to perform.
Do we need to do some test before proceeding? Means some kind of culture sensitivity?
No, it's not required. So usually in case of partial pandos, we do conjunctival swab sometimes, especially if the regurgitation is just 20 or 30%. Then we do conjunctival swab sometimes, especially if the patient is asymptomatic, there is no Roplas positivity, there's no mucocele formation or anything like that. We can proceed with surgeries in such cases also after doing a conjunctival swab. But in cases that we have performed DCR, some studies have documented that conjunctival flora stabilizes after around 3 to 4 weeks, and that is when we would like to perform the intraocular procedure. And if the intubation is in place, we ideally remove the intubation after 30 days of insertion. So after that removal, we can perform the surgery in a week.
Okay. Just last question, curious about the setup. You have shown an excellent setup. What I wanted to ask is whether the setup is mobile or it is like fixed to OT and like OT specific setups, or is it possible to have a mobile setup?
So the one that I have shown is well, technically that cart is on wheels. So yes, it is definitely mobile from one room to another, but it is not a portable setup. So it cannot really move places or hospitals. It is a definitely fixed setup, and that endoscopic card that I have shown actually can be used for any other endoscopic surgery other than nasal also. So you say gastro or any arthroscopies or any other scopy basically, because that is just a display unit, a light source, and a head camera. So the power basically lies with the telescopes that we use, the different telescopes that we can use with that kind of a setup. Specifically, if we want portable nasal endoscopes, they are available. Of course, they look like a really large suitcase, and they have a display unit and a light source combined within the same.
Okay. So basically, it's like partially mobile setup. And if a multi-specialty is already hospital is already having a camera and a light illuminator, then the endoscopic part is portable. What I
Absolutely.
understood. Yeah.
Absolutely. Yeah.
Just a last question, or we'll request you to give a summary and take-home message to our audience.
Yes. Before concluding, I would just like to mention that there are a few limitations of this procedure, particularly in cases after trauma, where the anatomy is not predictable and where the sac can itself have trauma, or there can be screws or other things within the sac, or the sac can be malpositioned, and the bony anatomy around it also may not be normal. It is always advisable and preferable to do an external DCR. In case of lacrimal sac diverticula, where we need a complete opening and clearance, because sometimes the diverticula can extend in areas where the nasal endoscope may not go. So in those cases, an external view is much better. In case of lacrimal rhinosporidiosis, because you want to ensure that all the cavity is being cleaned of the particular organisms. If there is any need for additional external surgery where anyway the scar is going to be placed, then definitely an external DCR can be performed. And last but not the least, if one feels at any time, even during the procedure, if this is getting out of hand and this is not in our comfort zone, we can convert to an external DCR even on table. And of course, that consent must be taken prior to the surgery from the patient. And most of the times, it is not such a problem, and the conversion can easily happen. So I would just like to conclude that how do we start? From where do we start? So start examining patients using the endoscope. Get familiar with your instrumentation, identifying normal anatomy, understanding the nasal variations. And the easiest way to do this is by examining the DCR ostiums that we have already performed. So this gives us a hand in the OPD itself, how to use an endoscope, and we can proceed from there. Once we do get a good hand-eye coordination, how do we proceed with it? So instrument handling, because sometimes we need to use both our hands. One holds the endoscope, the other is using instruments, and we are operating with it. And of course, our operating hand is our dominant hand. So the portion used which with you hold your endoscope is going to be your non-dominant hand majority of the times, which is your left hand. So you need to have a good, strong hand-eye coordination for that. And it is advisable to proceed step by step in successive cases. So आज मैंने यहाँ तक किया, next case में मैं और proceed कर सकते हैं. So even that can be done. And one can always have a backup. So keeping an open mind, having help from an experienced surgeon. And like I mentioned before, converting to external DCR, because that is one big advantage we have over any other surgery that can be easily converted into an external DCR. So thank you.
So this was all about endonasal DCR, which I labeled as patient's demand of HSC, where it needs faster healing, smaller incision, and cosmetic grade surgery. So I heartfully thank Dr. Richa for her excellent presentation and meticulous approach to endonasal DCR. And she has taught us very clearly that endoscopic DCR is going to be the future of DCR. So this is your editor Chakshu, Dr. Saurabh Mundhada, signing off, and hope to see you soon in next episode of Chai Pe Charcha. Thanks, Dr. Richa.
Thank you. Thank you for having me.